Yes, please invite your friends. Thanks for joining us. We'll go ahead and get started then because we've got a few of you here now. So I want to ask you guys one question before we get started, and that is, if you were hypothetically going to take the NCLEX tomorrow, how prepared do you feel on a scale of 0 to 10, with 0 being not at all prepared and 10 being the most prepared? Because we're nurses, right? We got to quantify things. I can't just ask you, are you ready? But scale of 0 to 10, how prepared does everybody feel if they were going to be taking the NCLEX tomorrow? Because I would say I'm probably about a 6 or 7. It's a hard test, and my weak area has always been maternal OB stuff, and so I would be the lucky one that got like all OB content. Okay, 5, 6, 7. 7's pretty good. All right, seems like everybody's kind of like a 5 to 7. Oh, Himavi's a 9. That probably means you've been using NCLEX Bootcamp to study, doesn't it? So, all right, good. Everybody's kind of all over the board. Well, I'll say by the time that you leave here today, I hope that you're going to feel like you're at least a couple points more prepared out of 10 than you were otherwise. And so, great. Let's go ahead and get started. My name is Dr. Emily. I'm one of the co-creators here at NCLEX Bootcamp. You're also going to see Dr. Courtney moderating in the comments. She's our psychiatric expert. And so between the two of us, we're going to try to answer all your questions. Either she will in the chat. If you ask me a question, there's a little bit of a delay. And if you see me looking off to the side, that's what I'm doing, is just looking at your comments. So please, guys, pitch in, participate. I'm going to be asking you a lot of questions throughout, and I promise you the more that you participate, the more you're going to learn and the better you're going to retain what you learned today. All right? So let's go ahead and get started. We are so happy to be talking to you about answering next-gen NCLEX case studies. So first, we're going to look at how these cases are formatted, and then we're going to spend most of our time teaching and practicing how to think like a nurse. And so this is really the big difference between the old NCLEX and the new next-gen NCLEX, is that the new NCLEX expects you to know how to think like a nurse, and they test that using their case studies. And so we actually have 50 case studies online that we use to give you guys plenty of practice with, and we're going to be going through this one today, but this is exactly how it's going to be set up in the actual NCLEX, where unlike the old NCLEX, which you've probably heard was vague, and that's true for standalones, you have just enough information to answer the question, but that's not real life, right? You guys have been in the hospital and you know that no patient is ever going to have just one disease or one medication on their MAR, right? They've got 10 of each and more problems and needs. And so this next gen format is much more reflective of real practice, and that's why they made the switch, because this is going to test your clinical judgment and critical thinking better. And so just like in real life, you're going to have a patient chart that you can click through. We can review their H&P, our assessment findings, vital signs. This can also unfold over 6 items where you get more information. And so we're going to go through this and practice in a little bit more detail, but this is essentially the format where you've got a 6-question case study, and you might not be familiar with the clinical judgment measurement model, but it's really not so different from the nursing process, which you guys probably have heard of. And I'll talk about the similarities here, but I want to ask first, how many of you guys during nursing school had the opportunity to practice next-gen cases, or is this kind of the first time you had to wait until after you started your NCLEX prep after you graduated? So did you get this exposure in school, yes or no? So yes, the clinical judgment measurement model, this looks at our ability to recognize cues, or essentially to assess what's most important, because not everything we can give the same amount of attention, right? And then you're going to analyze those cues or diagnose and consider what could it mean, or like what disease processes could this indicate. Then you're going to prioritize those problems and generate solutions to address them, kind of like your care planning. Then you're going to take action, or actually implement an intervention to address those priority problems. Then finally, you're going to evaluate the outcomes and consider, did it help? Did my actions help to correct this problem? So these are the 6 steps and the 6 items that a case unfolds through. And if you've got a minimum 85 question length exam, you're going to have at least 3 full length case studies, which means that accounts for about 25% of your score. And this is the biggest section on the NCLEX that accounts for most of your score. So you really want to be prepared and feel comfortable in these next gen cases. And then if you require more than the minimum 85 questions, which is totally fine, and I think the average is at around 110 questions, so you are in good company. But if you require more questions, then the remainder, 10% of the remainder of items are going to come from these clinical judgment standalones. And that's like your bow tie questions, which we also have plenty of, and trend items that we have some as well. And so it looks like you guys have said some of you have, some of you had a little bit of exposure. Okay, so it's like half of you have practiced with next gen cases before. So those of you who didn't get a chance to in school, we're going to go through one today in detail and practice thinking like a nurse. And so the first step in the clinical judgment model is recognizing cues. And this is where we figure out what's most important. And unlike the old NCLEX, you are going to have a lot of cues to sift through. So we're going to kind of click through these case study tabs together. And I want you guys to get really practiced at reading this and kind of envisioning this in your mind. Picture this patient. Picture what they're feeling, what they're saying. Kind of keep this visual in your mind, because that's going to help you know, what do I need to feel most urgently about addressing? So we're going to read this together. Picture that in your mind and start to think about, what is the priority problem here? Be on the lookout for those priority problems of your ABCs. And then keep in mind that these case studies do unfold. And so you're going to be told when they unfold. Here at the top, you're going to say, the nurse has entered a new nurse's note at this time. And each time the case unfolds, revisit that mental picture and see if you need to think about it differently. Because your patient they could start in the emergency department and then be admitted to the OR, or they could even be discharged home from the hospital and this care continues. And so knowing where you are and what resources you have is going to affect how you answer the question. So, all right, we're going to read this together. I'm going to highlight things that kind of stand out to me, and I want you guys to be thinking about any issues of ABCs that you see, and then call them out in the chat. So, all right, we've got this 57-year-old client. He's in the emergency department. He's saying he's been feeling short of breath and has had a cough for the last couple days. He's been sleeping on 2 pillows at night, and he wakes up coughing several times a night. He's been feeling very fatigued, and he spends most of the day in the bed or the chair. So keep this picture in mind as we're building and getting more information. This man who's 57, maybe he came in from work for this or has been missing work. He's short of breath, he's coughing, he's upright, he's anxious. So keep this in mind. We're also told he's got quite a bit of medical history, all of these cardiovascular risk factors, right? Hypertension, hyperlipidemia, angina, and diabetes. He's also concerned that he is unable to afford his medications. So a lot to think about here, and be keeping in mind what your priority problem is. And before we read these other tabs, I want you guys to start. Okay, so several of you has said shortness of breath. All right, so is our big problem shortness of breath, respiratory related, or something else? Be thinking of that. So we go in to assess him. He's oriented, that's good, but then we have crackles in all lung fields, so our breath sounds are not clear. We have an S1, S2, and an S3 present, and those of you who know, tell me, what does an S3 mean? That should tell you something specific, so what does that finding mean? Then our bowel sounds are normal active, our cap refill is normal, our pulses are normal, but then we've got 1+ pitting edema in our bilateral lower extremities. So adding to this picture of this guy who's anxious, coughing, short of breath, when we go assess him, his legs are puffy, he's got crackles in his lungs, and he has an extra heart sound. So there's quite a bit going on here. You guys have added crackles. So yes, shortness of breath and crackles. I agree with those of you who are calling that out. Mary and Olayemi, nice. Then we go take his vital signs, and our temperature is okay. Our pulse is a little elevated at 115. We're a little tachypnic at 25 breaths a minute. And then our blood pressure is a little high at 149/93, and our pulse ox is 89%. So I agree with those of you who are calling out crackles and shortness of breath as big priority problems here, and those are definitely issues of breathing. So here we're being asked to select the top 4 findings that require immediate follow-up. And so this is stuff that I need to address this right now. This is not something that can wait. And so we're going to go through and we're going to decide whether some of these do or do not definitely fall into our top 4, but a little NCLEX tip for you. If you're ever asked to select a certain number of options, make sure you select all of them. So pick all 4. Don't pick 3. And if you have to guess on the 4th one, just go ahead and guess, because on these items, you don't actually lose points for selecting an incorrect option. You just miss points you could have gained, versus regular SATA items where if you select one that's wrong, you get points off. So in regular SATA, only pick the ones you're absolutely sure of, but in select in, like this, pick all 4 or pick all 3 or however many you're being asked to. So let's pick 4. And I'm going to go ahead and say you guys have chosen, all of you have said shortness of breath and crackles. So I'm going to agree with you and go ahead and pick those 2, crackles and shortness of breath, because this is what we identified as our big problem. This is an issue of either airway or breathing, and we'll talk about that. But he can't breathe. And when we listen to his lungs, when you hear crackles, that means that there's something happening where that air is trying to move in the alveoli. So there's something that's getting in the way of his breathing, and that's creating some other problems for us that we saw here. So let's consider which our other 2 might be. So the cough. Is the cough something that I'm going to immediately follow up on? And a couple of you have said cough. Yeah, so this is where I would say, yeah, cough kind of sounds like a respiratory finding, right? So if you don't quite understand how to prioritize, you might want to address that first, just because it's respiratory in nature. But how would I follow up on that? What would I do about his cough? Like give him a cough drop, give him a gargle. None of these things seem really high priority, so I'm going to hold off on that. Only pick that if I don't have any other respiratory findings. Then the edema. So we're told he's got pitting edema in his lower extremities. Now this is problem, right? This is not a normal finding. This is a problematic finding. But again, how would I follow up on that? Would I just elevate his legs? It's not something that seems urgent. So we will come back to this one maybe. Then respirations. Several of you guys pointed this out as well, and definitely. So tachypnea, remember, is one of your early signs of hypoxemia. So this is compensatory. He's breathing quickly, trying to get more oxygen in because his pulse ox is low. And several of you guys have pointed that one out already. So yes, together these 4 findings tell us that we have got a priority respiratory problem. So he's short of breath. When we investigate further, we find he's breathing fast to compensate for a low pulse ox. And that's probably because at the level of the alveoli, there's something there that's creating crackles. So I agree with these top 4, but let's consider the others. Blood pressure. Now, a couple of you chose this one, and this is an abnormal blood pressure, right? But is this abnormal for this patient? And this is where you have to keep the whole big picture in mind. And so this guy, remember, he has a history of hypertension, and we don't even know that he took his medications this morning. He's been struggling to afford those, so he might not have even taken them. And this could be just a normal blood pressure for him. Or he could be stressed out. He's in the emergency department after all. So it's not high enough for me to be too concerned. If he had warning signs of dangerously high blood pressure, like headache or blurred vision, then I might be worried. But he doesn't. Don't read too much into it. We only have a high blood pressure. And so that's not more concerning to me than these respiratory findings. Then his inability to afford medications. This is very important to address at some point before he's discharged, if he is admitted. And so right now is not the right time. If I'm gonna call a social worker in to come talk to this guy about available resources, he's not gonna hear any of this. He can't breathe and he's anxious, and we can't wait, right? So it's not this one. And then the history of chronic stable angina. So that is probably contributing to his symptoms right now, but like the others, what am I gonna do about this? Just ask him questions about it, documented in this chart, nothing. So these are the top 4 things that I want to immediately follow up on, are these respiratory findings of insufficiency. So, and we're correct. And you guys will see that our average and our question bank, it was only 1 out of 4 points here. So those of you who got more than 1 correct, you are already ahead of the curve. And if you are not great at prioritizing, which it's a very hard skill, and I'm still even learning it as a nurse, but we have got some new cheat sheets for you guys. One of them, our kind of fan favorite, is our prioritization cheat sheet that teaches you our prioritization pyramid and how to think through these prioritization questions. And so if you stay till the end, Courtney is going to be giving you a link in the chat to tell you how to access all of our cheat sheets for free. So stay tuned for that. Now, okay, our next step is going to be analyzing cues or figuring out what could it mean. And the NCLEX might ask you this in a couple different ways. Either what conditions are they experiencing or at risk for experiencing, what disease processes could cause those findings, or how would I know if this or that complication was happening. So keep in mind that big picture problem as we go through this. So when I'm considering analyzing these cues, we're being asked, the nurse recognizes that crackles throughout the lungs in this client are due to either infective infiltrate, collapsed alveoli, or fluid accumulation related to either pneumonia, heart failure, or reduced mobility. And we're going to talk a little bit about how these findings might create crackles, but I want you guys to go ahead and make a guess if you can, and give us a guess in the chat box so that I can see how you're all doing. So, all right, let's talk about crackles. And how many of you guys have had an opportunity to hear crackles either in clinicals or on a patient if you're already working? And if you have, you would know it's pretty distinctive, right? If you haven't heard crackles before, this is described as kind of a Rice Krispies snap, crackle, pop sound. And if you actually take a little bit of your hair and roll it between your fingers next to your ear, that's pretty close to what crackles sound like. And so this happens whenever it was explained to me, and I like to remember it as if you're blowing bubbles through a straw. So we've got gas, oxygen that's trying to come in, carbon dioxide is trying to go out, but we've got something in the way. And that could be either infection, like pus in maybe pneumonia, or in heart failure or some other condition of fluid overload like kidney failure, maybe some fluid that's accumulated there, pulmonary edema, or even collapsed alveoli. So patients after surgery, for example, when they have this reduced mobility, they might develop atelectasis where their alveoli kind of collapse a little bit, and then if they cough or take a deep breath, hopefully they'll pop open. And so any of these things could cause crackles, but we have got only one that's most likely. And so I've asked you guys to kind of leave a guess. And all right, y'all have heard fluid accumulation from heart failure. That is kind of the consensus. All right, fluid accumulation and heart failure. Very good. So how did you guys know that? And we didn't talk about this yet, but yes, that S3 heart sound, right? This pitting edema in the lower extremities, those tell us he has too much fluid on him. So I agree that I'm very suspicious for too much fluids, for fluid overload. How would we know if he had an infection? So what other findings, because somebody who has an infection like pneumonia, they would be short of breath, right? But what other findings would we see that would tell us that it's related to infection? And I'm thinking something like, what about his cough? If he was coughing up yellow-green sputum, right? Maybe what about his vital signs? If he had a fever, or if we had lab results here, I might look at a white blood cell count. Yep, Faith says temp, Mary says high temp, yes. And so we can kind of rule out or recognize that that's less likely because he doesn't have a fever, yellow-green sputum. He doesn't have body aches or chills, or someone in his house isn't sick. We don't really have any clues for that. And then for the collapsed alveoli and reduced mobility, that's not impossible, right? He did tell us that he's been kind of fatigued, spending most of the day in the chair. But remember, when you hear crackles from atelectasis, they tend to clear with coughing. So if you hear it and you're not sure, maybe it's first thing 7 a.m. assessment, your patient's been taking slow, shallow breaths all night, you can just ask him to kind of cough, and that should pop open those atelectasis areas. But he's been coughing for 2 days now. And when I listened to his lungs, I didn't hear any absence of breath sounds over one lung field or diminished. There's just crackles. So let's look at how fluid accumulation from heart failure might cause crackles. And so just a quick review. So basically, if your heart is strained by any number of things, but this is most often hypertension, which our patient has, and coronary artery disease, which our patient also has. He's got stable angina. And so over time, that high blood pressure strains the heart, that kind of wears it out. And if you've got coronary arteries that have atherosclerosis in them, it's got a limited blood flow or blood supply. So we have too much demand for oxygen and not enough supply. And so over time, the heart gets weak and it can't pump blood forward as well. So because blood can't move forward well enough, your organs get less blood flow, and that blood instead backs up into the alveoli. And so this is what pulmonary edema is you've got fluid that's literally obstructing the ability to get oxygen in and carbon dioxide out. So that could definitely create crackles. And so we'll answer that. And we're correct again, and only 51.8% of people got this right in our bank. And so if this is a topic you guys struggle with, you know that all of our case studies have these detailed rationales explaining the correct and the incorrect answers, and then give you kind of all this explanation that we've talked about here in video format as well. So great job. Next, we're going to be looking at step 3, which is prioritizing hypotheses. Again, with the prioritization, this is always so important. And for step 3, we need to figure out, where do I start? And the NCLEX might ask you this as, what is the client most likely experiencing? Or are they at highest risk for? Or maybe they'll just say, what do you need to do first? And I like to think of this like this. If I can only do one thing for my patient and then walk away and my shift is over, what is that one thing going to be? If I'm going to do just one thing and nothing else, what will solve this problem the most directly and quickly? All right, so let's consider that. We're being asked, the client is at highest risk for developing blank, and that's either going to be respiratory failure, acute kidney injury, sepsis, or pulmonary embolism. And so I want you guys to drop some guesses in here as we talk through this. So here, the client is at risk for all of these things, right? But we need to figure out what they're at highest risk for from heart failure. So are they at high risk for respiratory failure? And I think you guys know this one, right? We've been talking about this as our priority problem. We've got respiratory insufficiency, we've got crackles from heart failure, and he's already on his way. We've got a low pulse ox, we've got tachypnea, so I'm definitely worried about respiratory failure with him. But what's our next one? And a couple of you have said AKI, drop in some other guesses. Okay, so let's think about each of these. So is somebody at risk for acute kidney injury from heart failure? And you guys have guessed this. Right, because remember, if the heart can't pump blood forward well enough, not only is it backing up into the lungs, risking respiratory failure, but it's not getting to the organs. And that is going to put you at risk for any kind of organ damage. But the kidneys are especially sensitive to this because they get 25% of your cardiac output. So that means for every liter of blood that your heart pumps, 250 mils of it is destined for the kidneys. They depend on a lot of blood flow. So the second that your cardiac output drops, your kidneys start to suffer from that reduced perfusion. So I am worried about this, but I'm not sure it's the highest risk yet before looking at these other two. So let's think about this. So sepsis. Who is at risk for sepsis? Patients who have what kind of problem? And some of you might say, well, anybody in the hospital is at risk for sepsis. And because anyone in the hospital is at risk for infection, that is true. But we typically worry about somebody developing sepsis if they already have an infection. And so remember, we decided we don't have any yellow-green sputum, we don't have any fever, we don't have any elevated white blood cell count. So this is a lot lower of a risk unless he already has an infection present. So I don't think it's this guy. And then pulmonary embolism. So if he has prolonged immobility, if we hospitalize him and fail to give him those Lovenox shots or put SCDs on him, then he could develop a DVT and maybe a PE. But we don't really have signs of a DVT. We've got bilateral lower extremity edema. If you had edema on just one leg, that might be more concerning for a DVT, right? But if he's got it in both legs, as well as all these other fluid overload related findings like our S3 and our crackles, I might be more suspicious for that. But because he has all of these, that is, I agree with you guys who guessed this, what my other one is, acute kidney injury. So respiratory failure because blood backs up from the heart, acute kidney injury because it's not moving forward from the heart. And we're correct. So yep, 1 out of 2 points is our average. So you guys are guessing really well. You guys are ahead of the curve. Excellent job. All right, so next, generating solutions or figuring out what can I do to address this problem. And the NCLEX might phrase this as which interventions are indicated or not indicated, or maybe which actions would address that priority problem we identified, maybe which actions would worsen the priority problem, because that's always a risk, is that something we do could make it worse. And so I want to point out that your ability to answer at this part of the case study depends heavily on your understanding of the content. Because if we at this point didn't know why this patient was short of breath, I wouldn't know what to do for him, right? Because if he was short of breath from pneumonia, I'd give antibiotics. If he was short of breath from a PE, I would give heparin. And we'll talk in a second about if he's short of breath from heart failure, what we would do. But it is important that you can understand what's happening with the patient so you know what you need to do to fix it. And so that's why all of our case studies have this kind of built-in content review video at the end to teach you this content and have that kind of content review to prepare you to clinically think and generate these solutions. So let's look at step 4, where we need to select whether each intervention is anticipated or not anticipated. And so let's take these one at a time. Do we need to get blood for a blood culture? And let's consider this at the same time as number 2, sputum for a sputum culture. Okay, a couple of you guys, Mariette and Olayemi, you've already guessed at some of our interventions for heart failure, but I don't see any guesses for blood for culture or sputum for culture, and that's because this would be indicated for what problem that we suspected. This would tell us if we had an infection present, right? Very good. You guys are guessing really well. So yeah, we, again, don't have a fever, don't have a white blood cell count, we don't have yellow-green sputum. I don't think this is an infectious problem, and stopping to do these things is just going to waste time and be a waste of resources. All right, next, do we need to prepare for an echocardiogram? And this is how the NCLEX likes to test whether you know what a procedure is indicated for. Do I need to do it for this patient or not? And an echocardiogram, if you guys have never had a chance to see this, it's pretty cool to watch at the bedside. But the patient turns onto their left side, and then it's just an ultrasound that visualizes the heart and its valves, and each pump of the heart, you're able to see blood leaving each of the 4 chambers. And so this is used, you guys said yes, good. So this is used to tell us about the heart function, and we can actually visualize, is the heart weak? Is it, are the walls thickened? And do I have some obstruction or valve problem? And so yes, this is gonna tell us the severity and presence of heart failure. Then do I need to draw serum renal function tests? And this is just a fancy way of saying a metabolic panel, right? Either a basic metabolic panel or a complete metabolic panel. That's going to tell us our BUN, our creatinine, and then all of our electrolytes. And so not only is it important that we look at the BUN and creatinine to see if he has an acute kidney injury happening, but we also need to look at some of the electrolytes in anticipation of a medication that you guys, some of you remembered we might be giving. So yes, we do need to look at his renal function to figure out if there's kidney damage and if we can safely give some meds to treat the fluid overload. Then administering supplemental oxygen, I am going to go ahead and answer yes for this one because I think you guys know that somebody who's got a pulse ox of 89%, unless they have COPD, needs oxygen. So yes, this is anticipated. Then get a 12-lead electrocardiogram. Yes, just like with the echocardiogram, this is going to tell us, is this heart rate high because he's in atrial fibrillation? Or could he be having an MI? Sometimes having a heart attack, he doesn't have any chest pain, but patients with diabetes don't always have chest pain, do they? So if he was having a heart attack, that can actually cause heart failure and cardiogenic shock, a really severe form of it. So I definitely want to get a 12-lead EKG. And then here's another lab. Do you guys know what this one measures? B-type natriuretic peptide, or BNP. I want you guys to tell me, what does that measure? Because this would be elevated, it would be elevated in heart failure. It would also be elevated in kidney failure because this is measuring fluid overload. So BNP is released from your heart whenever it's stretched from fluid overload. So yes, you guys are right. So for this guy who's having shortness of breath, I'm going to, of course, put on oxygen first, right? And then do my most urgent things like getting the 12 lead, because if he's having an MI, I need to get him to the cath lab. So I'm going to do those things quickly, stabilize him and with some oxygen, get a 12 lead, and then draw my labs. And at some point, someone will come for an echocardiogram. And then when we get the results of the renal function test, we'll know if we can safely do the next step. So let's see. You guys are doing really well. So, okay, this one was a little bit less difficult, but still challenging if you don't know what these things are. And so that's why it's important that you have a good grasp on content. And it seems like you guys do. So well done. All right, next we're going to take action or figure out now about this problem. What will I do? So should I do this or how do I do this? They might actually test your ability to safely and correctly complete an intervention. So here in this case, we need to answer this way. So we've got new lab results from 11. I look at my lab results. I've got a sodium that's a little low. I've got a potassium that is normal. And then this BNP is 600. So that's really high. So I've got stretch on the ventricles. And then why would heart failure make your sodium go low? How would that fluid overload do that? And I'll let you guys think on that one while we answer this question, which says we've got the diagnosis of heart failure. Which order should the nurse prioritize? So remember, if I'm going to do one thing for the patient and then walk away, what is that one thing that's going to help them the most? And several of you guys are already guessing. Okay, Victoria said fluid overload because too much fluid. Sunflower Baby 326 because too much fluid. Yes, if you have too much fluid, you're going to be retaining fluid and it's going to dilute the sodium in your blood. Very good. It's called dilutional hyponatremia. Good. Greg got it. Dilutes. Very well. Very good. All right, so of these to prioritize, we're either going to prepare them for a chest x-ray, give 2.5 of enalapril, give IV furosemide, or prepare them for that echocardiogram. And a couple of you guys want to guess furosemide, and let's consider these. So you guys, have you heard before that on prioritization questions, you need to assess first? How many of you guys have heard that, yes or no, that you need to always assess first? And so that might be true if you don't have enough information to act, right? But I don't need to look at this guy's chest x-ray or his echocardiogram to know that he has fluid overload and to know that it's safe to give a medication, right? So I don't need to waste time to get these more detailed assessments. I already have enough information to act. And then these two, they're going to address problems, right? Enalapril, what class of medication is that? You guys, the name will help you. I think those of you who have already guessed furosemide know what medication this one is, but enalapril, that's an ACE inhibitor, right? So that would lower the blood pressure, which we have an elevated blood pressure. So this would solve a problem, but yeah, by giving furosemide, that's going to diurese, and that's actually going to pull the fluid off. And because our problem is fluid in the alveoli, that's what we're going to address first. And if you weren't sure between these two, because, they're both indicated, we need to give both of them eventually. But remember, furosemide, what will that do to the blood pressure? If I give furosemide, is that going to raise the blood pressure or lower the blood pressure? Okay, all right. Prabpreet says that furosemide is a loop diuretic. That is correct. It is a loop diuretic. That means it's potassium wasting, which means if this potassium was too low, I would need to give potassium before giving the furosemide or use a different diuretic. All right, Florabelle says lower. Florabelle, I think you're joining us again. Thanks for coming back. So yes, furosemide would lower the blood pressure. Mary says it will drop it. Exactly. So if I give the furosemide and it causes hypotension, which it can, then I won't even need to do this at all. So you guys are exactly right. We're going to give furosemide, And 65% of our users answered this correctly. So if this is something you struggled with, come check out case study number 3. All right, so for now our final, if you guys are not members of our Facebook group, please go invite your friends and go ahead and subscribe to our channel here on YouTube as well so you can come back for all of our YouTube live sessions. Very good. So taking action, remember our prioritization pyramid that we went through, we were addressing those circulation and breathing issues first. Breathing, that furosemide pulls fluid off of the lungs, relieves that pulmonary edema, whereas giving the enalapril would really just address the blood pressure and circulation issue. So we prioritized breathing. All right, so finally, step 6, we're evaluating outcomes or figuring, did it help? Or was it effective, whatever I did? Or what signs might indicate a complication has occurred? And so here we need to answer that in the form of this teaching. It's 2 days later, we're being discharged. We're being discharged on enalapril, metoprolol, and furosemide. So we already established this is an ACE inhibitor for blood pressure, and furosemide is a loop diuretic for fluid overload. Metoprolol, you guys know this one, the LOL is a beta blocker. So this is going to kind of slow and perfect that heartbeat to treat heart failure. So we've taught him about these medications, and now we need to figure out which of these client statements indicate that that discharge teaching was effective or that our intervention was effective. So is it correct if he says it's best to take my furosemide first thing in the morning when I wake up? And the rule that I always remember with Lasix is Lasix lasts 6. It has roughly a 6-hour half-life, which means if you give it at night, that patient is going to be up all night peeing. So yes, this needs to be taken in the morning, and that's correct. Then I should avoid eating prepackaged foods and over-seasoning my food with salt. Yes, patients often think when they're put on a sodium restriction that all they need to do is stop using the salt shaker, but actually most of the sodium in our diet comes from packaged prepared foods. So this is correct. Then should he contact the healthcare provider if he gains more than 3 to 5 pounds or 2.3 kilos in a week? And several of you guys have guessed 3. All right, Rose says yes, yes. And you're correct, because if they gain, nobody gains fat this quickly. If they gain that much weight that fast, it's fluid they're retaining. And so that way they can up their dose of furosemide, come into the hospital, and we can prevent a heart failure exacerbation, which can be lethal. Then, okay, it is important to weigh myself weekly to ensure that I'm not retaining too much fluid. That's not often enough, guys, right? You guys know, how often do we need to weigh patients with heart failure? And it's more often than weekly. And they actually have really cool scales that connect to your app, like an app now on your phone, and the scale reads to you and notifies you if your weight has gone up too quickly. And the Braced Nightingale, which I love that name, says weigh daily. Yeah, you guys are right. We need to weigh daily. So this is not correct. This would require us to follow up and correct the teaching. Then, okay, certain over-the-counter medications like antacids can contain high amounts of sodium. Yes, many of them contain sodium. Some of them contain other electrolytes like calcium carbonate is in Tums. And so we want to make sure that they don't have any drug interactions. And we're correct. So well done, you guys. So all right, thank you for joining us today. You can find us on bootcamp.com/NCLEX or on any of our socials here. So thank you guys for joining. And I want to ask, do you guys have any questions? Do we have anything else here for you? And our references. So very good. Mary's correct. We weigh daily, same time, same scale, same dress. Yes, all the same things. All right, thank you guys for joining us. I hope this was helpful. I hope if you came in at a 4 out of 10 preparedness that you're leaving at least a 6. The NCLEX doesn't have to be so scary. Just come check us out on NCLEX Bootcamp. And remember that Dr. Courtney is going to leave us the link in the chat so that you guys can access all of our cheat sheets for free. And we know that you're going to find them helpful. And stay tuned for our future webinars on other NCLEX tough topics. Thanks.